Chaturvedi, 2.8 millimeter incision doesn't cause any difference. Everybody knows about it. And I said, if that is the case, what is the whole fuss about sub 2 millimeter incision cataract surgery? So that is the thing. By the basic purpose of making this presentation is that we can have universal incision location, universal port orientation for all the eyes, for all the patients. And if we are going to make our case streamlined, then the same surgery can be put to everybody and it will yield the same result. That's all. Thank you.
Thank you, Doctor. I think your point is very well taken up. I'll also like to enjoy the beginning.
Thank you very much. Take care.
Go on to the last speaker of this session, Dr. Ramesh is going to talk about congenital cataract, a very important topic, congenital cataract.
Oh, thank you, Chairperson and dear friends, staying for the last. All this time it was talk about adult cataracts, and we all know like congenital cataract is totally a different challenge, and we are not handling a miniature adult eye. It's totally a different infant eye where everything is different. It's a high hypermetropia, small axial length, the K reading is different, scleral behavior is different, the whole cataract, everything is different. There can be various causes. Like we need to know where we need to investigate them in detail, the metabolic disorders. That's where a comprehensive workup along with the pediatrician, unlike an adult cataract, we have to very much be watchful on that. And type of cataract commonly will be diffuse, total cataract, lamellar, zonular picked up during a standard screening procedure. If it is a posterior polar, posterior capsular, then at the nodal point causes a much of visual loss, should be more watchful. Anterior polar may not be much visually, is visually insignificant, so many times we need to observe them. So we need to know when to intervene. And starting from the basic evaluation, it's a real challenge. The most important thing is like they should look for a fixation, proper fixation pattern. If they have strabismus associated and nystagmus, we know that we are handling tough situations. They go in for a deep amblyopia. It's not just surgery alone. We need to have a long-term post-op rehabilitation. And a lot of vision charts. We can really have a one full day discussion on that. Simple patching test. This is a child with a unilateral cataract, see crying when the better eye is closed. And rule out history of trauma if it's unilateral cataract. No need to go in for an extensive systemic workup. Maybe it needs a B-scan retinal evaluation. Like bilateral cataracts, look for any inheritance pattern, any syndromes associated, other systemic features. Do a comprehensive evaluation before taking the patient for a surgery. And battery of metabolic investigations. 25 years back during our residency days, I still remember that we had a rampant rubella cataract. We do still get once in a while, but we always watch out for. Evaluate them wherever really required, then plan for a surgery. And the real pre-op evaluation, unlike in adults, the most important key is like all this evaluation has to be done under an anesthesia because we need to get all the information available, starting from the intraocular pressure, associated glaucoma, if there is anterior segment dysgenesis, and corneal diameter measurement, K value, axial length measurements, preferably by an immersion, not a contact biometry. And fundus, if there is a good view, then probably have a good view of the fundus. It's a lamellar cataract. B-scan wherever really required because we may be handling associated PHPV, retinal pathologies. So we need to be watchful. I still remember having, during my residency days, a radiation-induced cataract following a retinoblastoma treatment. I haven't had seen a child operated for an IOL post-retinoblastoma complications. So we need to be watchful. Wherever possible, gonioscopy because most of them may have anterior segment dysgenesis. And the another most important thing probably we all might miss out is a small simple rhoplastis because this was a real eye-opener for me. It's a child with a congenital cataract, see the amount of pus pouring out from the lacrimal sac. In an adult scenario, maybe we can still do, some of them still do a syringing before we take them for a cataract surgery. But then the importance of a rhoplastis cannot really be that important. So we will be landing up with an endophthalmitis in a child operated on a cataract. So you should always take it as a part of the pre-op evaluation. Because children do have, maybe it might be, looks like an insignificant epiphora, but it turned out to be a sac infection. Visually significant cataract, anything that is 3 millimeters and more in the central pupillary area, a total cataract that prevents fundus examination, and posterior cataract, especially the posterior nodal point, need to be operated. And strabismus and nystagmus, we are already late. Anything visual acuity less than 6/18, especially if it's a lamellar cataract, we do a lot of school screening program. When you pick up surprisingly lamellar cataract in this population. Ideal time to operate, nothing. In fact, as the textbooks say, we operate a bit late because of the late presentation to us. I wanted to more emphasize on the surgical steps, because surgery, every step is a challenging one, because always under general anesthesia. That's the best part. We need to have the best of the instruments, and the instrumentations, everything has to be perfect. I usually do a bimanual phaco and an adult cataract, so got used to a 2 paracentesis side port incision and tryphan blue staining wherever required, because if there is a dense white cataract like this, then certainly yes, we need to have a staining of the pediatric capsule also. And if there is a no IOL, less than 1 year, if you are operating and not going to put an IOL, we can prefer a limbal side port also. And the most important step of all is the anterior capsule management. As we all know, like lot has emphasized on the capsular rhexis, and herein, after initiating the rhexis, I always use my side port. So it's perfectly a tight chamber using a micro rhexis forceps. Almost every clock hour we need to re-grasp and release, because we have to plan for a real, aim for a real small capsular opening, because we are handling a very, very, very elastic capsule. It's not like your adult capsule. So this pull, change of your hand, change of your instrumentation all around is very, very important, because unless you have a 360-degree overlap of the intraocular lens placed in the back, the lens is not, it's going to be decentered in the back. So the anterior rhexis sizing is very important, and use of cohesive viscoelastics. You need to have the best of the viscoelastics, instrumentation, everything in a pediatric cataract. Never compromise on your techniques, your instrumentation, anything. And with this, once the anterior rhexis is complete, almost, initially we thought most of our surgery was really complete, but then let me come to the subsequent steps to show that there are certain other more important steps also. So this is for a demonstration purpose, ideally not a very dense cataract. It was right on the posterior pole. Being a last speaker, I think I can take some time if I don't mind, sir, please. And there are various options, but still manual rhexis is the smoothest of all the lot. And incision, again, it should be a very, I prefer a just limbal. There is a maximal healing, but we do, this is a lamellar cataract, nice zone of cataract. There's an insult in the intra-trend period. And lens aspiration, nothing much here. As a bimanual IA, if you are used to, it's very easy to do the procedure. And multiple hydrodissection to help to separate the epithelial cells. And posterior capsule, like I just wanted to mainly highlight on this. So the posterior rhexis is what is now the most important thing. Previously we were handling anterior rhexis was the most difficult thing. Now with the posterior rhexis, it is a must if you are handling a small child, less than 5 years at least, because unless we do a good central posterior rhexis smaller than the anterior rhexis, do a good anterior vitrectomy, because the anterior vitreous also is going to act like a scaffold for the lens epithelial proliferation. Visual axis opacification is almost close to 100% in a child if it is not done properly. So this needs a lot of skill. So once we become a master in anterior rhexis, then doing a posterior rhexis, this is what is being shown in the video on top. That has to be very well placed. It should be smaller than your anterior rhexis, because you have to put the lens in the back. Many times the lens can go into the vitreous if we don't properly inflate the back with cohesive viscoelastics. So highlighting on the posterior rhexis. In fact, by this, whenever we have a PC rent in an adult case also, we can still make it complete into a posterior rhexis and still put an IOL lens, premium lens in the back. So that's the importance of pediatric cataract surgery. IOL implantation, we need to bloat the bag and always an soft acrylic single piece intraocular lens in the bag, never ever in the sulcus. And incision through a small wound is very controlled, and always suture the wound.
Please try to summarize. Please try to summarize.
Yeah, so that's it, sir. That's a maximum. Always suture the wound, and wherever required special cases, we can use high-risk hooks like this somatic cataracts, capsulotomy if required, membranectomy, and difficulty in power calculation, we have to undercorrect them, we'll be handling. And the main thing is post-operative rehabilitation. These patients are going to be with you for life. I always tell my patients, children, they are going to outlive than me. So we have a real responsibility of handling these children, handling amblyopia, treating the post-surgical refractive correction, giving them the right time, the presbyopia correction when they go to school, and following them up lifelong. Thank you, sir. Thank you so much.
Thank you, sir.